Dr. Schmidt, thank you very much for your elegant presentation as usual. Ahmed Taha from Cairo University. My question is about your strategy of managing a patient with total SFA occlusion, and while during intervention you find the wire is passing very easily and you expect a sort of an acute event over a chronic lesion. What's your strategy of treatment in such cases?
Yeah, that's a good question. I think it also changed a little bit during the last years since we're using more drug-eluting balloons, since we try to not stent so much lesions and leave nothing behind. Of course, if your intention is to, if you have such a lesion, you're not sure, is it partially maybe thrombotic, you want to use actually drug-eluting balloons, you have to clean it out. It doesn't make sense to press the drug into the thrombus. So therefore, if this is your intention, we first use a thrombectomy device. We might also use local thrombolysis first and then continue with a DEB after some hours or a day later. Of course, we can also, go for other technologies like direct stent implantation, silver PTX, for example. Very cautious predilation, not to embolize, take the silver PTX stent, for example, or a Viabahn, for example. So I think it can go both ways, but it changed, as I said, a little bit recently.
Thanks for the speakers for excellent talks. I want to ask about the femoral task D lesions. And so far, the results have been disappointing. Even the data from the silver PTX has not been as good as the other areas. What do you guys think so far on task D lesions? The new Viabahn study showing superior results. Is that what you're using in your practice, or are you still shying away from it, or pushing patients toward bypassing? Task D is what we're struggling with so far. Patency has been pretty bad for these full metal jackets.
You're talking about SFA, sir?
SFA only.
Your question for
no takers, I'm not surprised.
It's a good question. So let's say it's a typical SFA occlusion from the groin, femoral bifurcation down to the adductor canal. 20-25 centimeter long occlusion. We would actually in our lab prefer first endo. So clearly in claudicant we would first advise exercise. If a patient is not happy, and there are quite a lot, I would say, younger patients, then we would first advise endo, and we would really try to be cautious to restrict our treatment, ballooning and stenting to that area which is diseased, not to destroy collaterals, not to go further down. And we don't see deterioration in these patients even if restenosis comes. So I think with all the technologies which we have so far, like drug-eluting balloon, for example, pushing out stenting, we can really push out stenting. For further options, we can, by many different endo treatments, push out bypass surgery for quite a long time. And therefore, I think this is a good way to go. First exercise, then endo. If this fails, maybe later on bypass. So push out bypass. If there are other type task D lesions like those going from the SFA over the popliteal artery down, there I think we do not really have very big proof that endo really helps a lot. I think we have to be more cautious not to burn bridges and to bring the patient in a more difficult and worse situation when we do this. So cautiously maybe endo, but clearly we would discuss these patients more with a vascular surgeon.
And with stents, are you buying the Viabahn data? Is that if you have to stent a long segment more than 20-25 centimeters, is that what you're going for?
No, we don't go for Viabahn. It doesn't really have a lot of tradition in Europe, I would say, so far, although due to the first randomized trial, it's not so bad. So we are actually rather following the treatment option of drug-eluting balloon and spot stenting. Try, as I said, to avoid directly stenting for the first intervention. Those patients will come back for further intervention. So if you don't use all the equipment at the first intervention which you have and leave it maybe with a drug-eluting balloon first and go for stenting later, I think this is a good way to do this.
I'd be interested to hear the perspective of the surgeons as well. Thanks.
In the US, as you're aware, our hands are tied because we don't have drug-coated balloons.
Exactly.
And the mentality of the US patients being that they don't like to come back. And if you get a failure at 1 year and the symptoms come back, it's failure of your doctor. So you have to get your best treatment up front as much as you can, which is very different with unraised, you're saying, because they got control of their patients, very different. And then our payment problem, as you know. So what we do in our practice is we put Viabonds in there, and then most of the failures of Viabond are at the end, especially the proximal end, if they come back with Zilver PTX, which is available, but once we get drug-coated balloons, then obviously maybe we can experiment with those.
Yeah, please go ahead.
Thank you very much for these very nice, informative presentations. For Dr. Mahmoud, please, you said in the last slide that you adopt an endo-first policy for below-the-knee interventions. Can I say why not to use a selective approach rather than an endo-first approach?
Why not to what approach?
Why not to follow a selective approach? For example, if you have a good surgical risk patient with focal lesion and a good vein and optimum circumstances for surgery with, you know, the durability of bypass or venous bypass is more, and hemodynamic changes will be better than endovascular intervention, especially with major tissue loss.
A couple of reasons. One is, if I may use this, a couple of reasons. One is that the CLI patients, as you know, especially when they're Rutherford-Becker 5 patients, their mortality rate is about 30% at 1 year. Okay. Now, Rutherford-Becker 4 patients, which is the rest pain, the mortality rate is close to 0. There's close to intermittent claudication. So, to the extent possible, if we can preserve their quality of life, we should. Now, endo-first approach, every series to look at, the limb salvage rate is about the same as a surgical bypass series. The patency is not. We all agree. The patency of endovascular is dismal. It's about 50% at best, except if you use drug-coated, drug-eluting stents. So if the objective is to heal or have a surgical site, a lower amputation heal, endovascular outcomes are the same as bypass. And if that fails, of course, bypass is always available. Now, as I mentioned to you, I'm in a surgical group, so I'm not in a cardiology or a radiology group. So our practice is about 70% CLI patients. We do 3 or 4 a day treatment. In the entire practice, endo first is the one, has to do with the quality of life of the patients.
Okay, let me conclude by one more last question to Professor Razavi. Now, a lot of in this region, a lot of the interventional radiologists are asking for privileges in their institution to have clinics and follow up the patients. What is your practice? Do you have a clinic in your practice? Do you see the patients pre-op? Do you see them post-op? How's your practice?
Yeah, there are 2 of us who are here with a background of interventional radiology. We don't need privileges to see patients. We're physicians. We can see patients. We have, from my training back at the Stanford days, we had our own clinics. We followed our own patients. Even when our surgical colleagues see the patients and they want me to treat them. Now, for economic reasons, when the patient comes within our group, sometimes we don't see them. They see the patient, I treat them, they follow up, or vice versa. However, my personal time, an entire day is spent in the clinic every week. And those are pre and post-op patients that come, you see them. It doesn't work without it. The days of being, it's interesting because if you look at interventional cardiology practices, they're going the way that interventional radiology used to be. That the surgeons saw the patients, they send it to us for those who wanted to be treated endo. We treated them, we send them back to the surgeons to follow the patients up. Interventional cardiology practices in the US, for economic reasons, they're doing the same. There's a group of them that only work in the clinic, and then they send it to their interventional colleagues who does the procedure, send it back to their the follow-up. That is a lot more efficient for the system, but as a patient care, have to do it. There is no other option. If you guys are an old model, that's gone.
Thank you very much, everybody, and thank you for being here. If you've got any more questions, please do meet the speakers at the coffee break.